A 25-year-old woman presents to the emergency department with a thrombosed hemorrhoid, complaining of severe pain. The surgery team is at the bedside for an excision. She is given 2 milligrams of hydromorphone IV for the procedure, which lasts less than 10 minutes. With local anesthesia and the relief of the excision, her pain rapidly improves. She spends an additional 2 hours in the emergency department for somnolence and respiratory depression, then is discharged home. How could we have done this better? When choosing an opioid analgesic in the hospital, there are several important considerations. Does the pain require an opioid? The World Health Organization analgesic ladder was originally developed to guide the treatment of malignancy-related pain. However, the ladder provides a common-sense approach to the question of when to initiate opioids. Mild pain should be treated around the clock with non-opioid analgesics like acetaminophen or NSAIDs. Moderate pain would indicate the addition of a weak opioid, while severe pain would necessitate treatment with a strong opioid. At each step, these opioid medications are recommended in addition to non-opioid medications and adjuvant therapy such as bracing or ice. Given the greater number of opioids available since the development of the ladder in 1986, the terms weak opioid and strong opioid are difficult to define. We will talk more about potency and dose later. How long will the pain last? This was the essential question in the patient with a bedside hemorrhoidectomy. The use of hydromorphone created a situation in which the drug outlasted her pain. Will your patient's pain be acute and quickly resolved, or will it be protracted? Duration of action is one of the most important criteria in selecting an opioid. Intravenous fentanyl is rapid onset and short-acting, with immediate analgesic effects after IV administration that last up to 30 to 60 minutes. Intravenous morphine has an onset of action of 5 to 10 minutes, lasting 4 to 6 hours. Intravenous hydromorphone, or Dilaudid, starts its analgesic action at approximately 15 minutes, lasting 4 to 6 hours. Given the similarities in pharmacokinetics of morphine and hydromorphone at equivalent doses, the decision between these two agents is largely based on provider and institutional preference. The immediate release oral preparations like hydrocodone and oxycodone also last approximately 4 to 6 hours, but have an onset of action 30 to 40 minutes. Continuous release preparations, extended release preparations, and methadone are the longest lasting agents and may exert their analgesic effects for 12 hours or beyond. What routes of administration are available? The oral route of opioid administration is the most common and easiest route of administration. However, some patients are unable to receive oral opioids due to their NPO status. IV opioids are always more potent, and there is no circumstance in which the same dose of an oral opioid should be directly carried over to an intravenous one. For example, 4 milligrams of intravenous hydromorphone is a much larger dose than 4 milligrams of oral hydromorphone. Whether you select intravenous or oral opioids for your patient, remember that the dose of the opioid determines its overall effect, not the route. Clinicians may fail to realize that fatal in-hospital opioid overdoses can result from oral opioids as well as IV. Providers should avoid the administration of repeated subcutaneous or intramuscular doses of opioids. Erratic absorption can lead to dose accumulation and respiratory depression. What is appropriate starting dose? There are several outstanding resources that describe starting opioid doses and dosing schedule. In adults, common starting doses are 50 to 100 micrograms of fentanyl Q1 hour and 0.5 to 1 milligrams of hydromorphone IV Q4 hours. The recommended starting dose of morphine is 0.1 milligram per kilogram IV Q4 hours, but this dose has not been adjusted to reflect the obesity epidemic. Many clinicians will use a smaller starting dose, for example, 4 milligrams of morphine. Many of our reviewed adverse events involve IV hydromorphone. While there are some differences in the literature, at the University of Massachusetts, our agreed upon calculation is that 1 milligram of hydromorphone is equivalent to 6.7 milligrams of intravenous morphine. Providers may feel reassured that 2 milligrams of intravenous morphine sounds like a low dose, but 2 milligrams of intravenous hydromorphone should not be administered as a one-time dose, unless you would feel comfortable giving that same patient 14 milligrams of morphine instead. Opioid-tolerant individuals often require higher doses to achieve adequate analgesia. However, these patients must be approached cautiously, given their increased risk of respiratory depression. For hospitalized patients, be careful about extrapolating the analgesic dose from the amount of medication provided in the emergency department. Emergency department care frequently requires painful procedures. As the patient's pain improves or as the patient receives less noxious stimuli, their opioid requirement will lessen. Is there a dose adjustment required? Dose adjustments of opioids are required in patients with renal or hepatic failure. For example, the intravenous hydromorphone dose should be reduced to 25 to 50% of the usual starting dose in patients with renal or hepatic impairment. There are similar dose adjustments recommended for morphine and oxycodone. Alternatively, fentanyl is thought to be safer than other opioids in patients with renal impairment, as it is primarily metabolized by the liver. Is this patient high risk, and how should she be monitored? More details on risk factors and monitoring can be found in other segments. Share this video with your team and help make sure that everyone is able to describe important steps in selecting an opioid.